epidermis and then the dermis. In the dermis, we have these 5 layers. I don't think you need to remember these 5 layers. You just need to know, I think the first layer is the stratum corneum because we can see a lot of changes in this layer. And then stratum lucidum, I don't think you need to remember this. And then we have this layer called the stratum granulosum. We always call this granular layer because we have this purplish keratinocyte differentiate into this layer. We can see this purplish color. This layer is really important for some differential diagnosis, especially in the dermatitis chapter. Then we have this stratum spinosum. We also call this spinous layer. The reason why we call this spinous layer, because you can see this is the keratinocyte in this layer. We have this desmosome to just attach to each other. So this desmosome, especially in the spongioses, dermatitis background, you see this desmosome. So just like a spider leg, just connect with each other. Then we have this basal cell layer, that is the stem cell of the epidermis. So if we have any pathology changes, destroy this layer, and then the basal cell layer can proliferate to have all kind of this differentiation. And then of course, after this we have our dermis. And the dermis, we usually talk about superficial dermis, aka papillary dermis. That means this kind of really superficial area. We do not have a really distinct to show which is superficial, which is deep, but sometimes we can see some changes just pretty close to the epidermis, and then we can know that is superficial dermis. And then in this picture, we could not see deeper dermis. That is the reticulated dermis. And then there is a junction we call DEJ junction. That is this area, the epidermis and then the dermis junction, DEJ junction. This is also really important when we see some dermatitis. Then here I just highlight this desmosome between the keratinocytes and then hemidesmosome. The reason I highlight these two structures because in pemphigus vulgaris, we have the antibody to attack this desmosome. And then in pemphigoid, bullous pemphigoid, we have the antibody to attack this hemidesmosome. So I think in the text, they will usually to ask you. Then the derm path, there is a characteristic feature is always we correlate with the photo. I don't know in other practice, do you see the photo of the lesion? But in our Geisinger Medical Center, our dermatology usually take a photo to show you where they biopsy these lesions. So you can always have really good clinical and pathology correlation here. Here I just show you A, B, C, D. So actually A and B are similar. They are flat lesion. The change is just like less than 1 centimeter or more than 1 centimeter. So less than 1 centimeter, we call this macule. And then more than 1 centimeter, we just call it patch. Then we have another two pair. There's the papule and plaque. Papule is less than 1 centimeter but elevated solid skin lesion. And then the plaque is kind of also raised skin lesion but large than 1 centimeter. Then there is some buzzwords when we describe a lesion. I think this is the most important thing, I think, for this term. The first one is hyperkeratosis. That means thickening of the stratum corneum. So this is the clinical photo, and then in the histology slide, we can see this thickening of cornea layer. So we call this hyperkeratosis. But you could not see any nucleus inside. If you see nucleus inside, that is perikeratosis. So here is the parakeratosis, because normally our skin will mature from the basal cell layer, and then they will go up and up and up. Usually it will take about 3 to 4 weeks. Then they just lose their nucleus and then go to this stratum corneum. But if there is something wrong with any layer in the epidermis, they will go up too fast. Then they do not have enough time to lose their nucleus, so we will have this parakeratosis. So why these two terms is really important, because if you see hyperkeratosis, usually that means this lesion develop really acute. That means this lesion, you have these changes really fast. And then if you have parakeratosis, that means this is subacute or even chronic changes of the skin. Then another term is hypergranulosis. That means this purplish cell layer, they have thickening. Usually just, I think just 1 or 2 layer of this kind of granular layer cells. But you can see it right now, I think at least 3 or 4 cells stacked together. So this is a hypergranulosis. So one classic feature hypergranulosis is lichen planus. And if you can see diminished hypergranulosis, that means you lose of this granular cell layer. Then you have hyperkeratosis and also neutrophil in the stratum corneum. That is the classic feature of psoriasis. Then the other one is spongiosis. I think in our first case, we will see these changes. So I don't need to talk about it here. Basically, you just see this intercellular space filled with fluid. So you can see the keratinocytes just like lose their attachment. Then we have these two terms really similar. One is acanthosis, the other one is acanthosis. Acantholysis, that means your keratinocyte just break apart. And then acanthosis, that means you have thickened epidermis. This is the acanthosis.